Well, hello, everyone. My name is Jeffrey Bettag. I am the host of the Benjamin Rush Institute's virtual event series. Benjamin Rush Institute provides educational debates, lectures, panel discussions, and other events such as this one that emphasize the primary role of the doctor-patient relationship and free enterprise for ensuring optimal patient outcomes at affordable prices. We'll be taping today's presentation so our Benjamin Rush Institute medical chapters can view and review this as a group or as individuals. And this recording will be available on our BRI YouTube channel no later than Tuesday next week, where you can explore other lectures such as this one that have spoken to us in the past. And in this edition of the Benjamin Rush Institute's virtual event series, our guest is Dr. Tanner Moore. Dr. Moore is the medical director at Clearwater Health Direct Primary Care. He's board certified for the practice of family medicine and is a graduate of West Virginia University School of Medicine. And today we're going to speak with him about direct primary care, or DPC as it's often referred to. We're going to talk about the history of DPC medicine and explore some of the reasons why patients find DPC beneficial and why doctors increasingly are moving to DPC practices. Welcome, Dr. Moore. I also saw you are a military service member, so I want to thank you for your service before we begin. And maybe we should start with an explanation of what DPC is and why it's become so popular with doctors and most importantly with their patients.
Yeah, perfect. Hey, thank you so much, Jeffrey. I'm really happy to be talking with BRI. I actually stumbled on you guys' website a couple weeks ago and just reading the mission and going through everything that BRI has been able to accomplish. I was happy to join as a member and reach out and see if we could kind of work together with the Direct Primary Care Alliance. And I'm really glad to be bringing this to fruition now. Let me just
Yeah,
get this slideshow going. To answer your question, direct primary care was created with the understanding that you can always get more than you have because you can become more than you are. Now, of course, the other side of that coin says unless you become more than you are, you'll always have exactly what you've got. Physicians had become trapped in a system that was hurting them and their patients. And DPC was created because we had to grow and change in order to improve that predicament. Direct primary care is a clean break from the conventional medical system. You can forget hospitals and think more of Netflix. Our members pay a low monthly membership fee in exchange for same day, next day appointments. They can access us via text. We do house calls. It's the old time doctor thing that like our grandparents had access to. We also provide a huge discount on labs. Also imaging and prescriptions, like up to 95% discount on them because we do this thing called client billing. We do all of this completely outside the insurance marketplace. It's just you working for your patients. We're not concierge. Concierge doctors pull kind of a double dip by charging a high annual subscription in exchange for access. They still charge your insurance plus copays and deductibles in exchange for the care they provide. And they usually require their members to carry the highest level and best paying insurance plan because they want to maximize those profits for every visit. Now, I know right now the students out there can be feeling a lot of apprehension about choosing a career in primary care or just as a physician in general. You're on a path where it's unclear exactly what lies ahead, and the messages coming back from the people further down the trail can be pretty discouraging. But there's a reason you're going into primary care and medicine. It's not because we see way too many patients in a day. It's not because primary care has become overrun with mid-level providers. No, you came into medicine and primary care because of our legacy of being there for our patients, holding a respected position in the community, and putting families first. And I have good news. You made the right decision and you're going to love being a doctor. Some of your predecessors refused to surrender our specialties, and they've been fighting for your future and paving the way for you to live the life and be the doctor you envisioned on your med school application. Let me tell you where we started, where we went, and now where we're going. So this talk's called The Resurrection of Primary Care. Like we are saying, I'm Dr. Moore. I'm the chairman of the Resident and Medical Student Department for the Direct Primary Care Alliance. And I would recommend anyone interested in primary care look into joining the Direct Primary Care Alliance. And I'll share a link at the end where they can do that. It's the best way to gain more information and then resources from us as we act as stewards for anybody working to get into direct primary care. And it's all free for any doctor in training. Your attendings have already paid your way. So you get those discounts at no expense. Little bit about me. So I served in the Army for 11 years. I've got a farm outside of Fort Bragg, North Carolina. I've got a wild, wonderful, rugged wife and two great kids. And I started working in medicine as an EMT a long time ago, and then went through medical school and residency and a service obligation with the Army. And after graduating residency, I was able to do a significant amount of moonlighting in the ICUs during COVID, which was kind of a defining moment for residency graduates of 2020. So I was able to get a lot of just really high yield experience in a short amount of time. I love being a full spectrum family doctor, and I'm still womb to tomb. I delivered both of my children, and my experiences have really kind of built me into the person that I am now and given me the fortification to go and do some other things in medicine that a lot of doctors haven't felt comfortable with. I learned about DPC during my second year of residency, and it's kept me feverishly awake ever since. I'm now the medical director for Clearwater Health Direct Primary Care in Apex, North Carolina. And we're an expansion model, so we'll be pretty much everywhere we can be over the next decade. We'll be doing a lot of that growth. And now DPC was created with the understanding that health, wealth, and time are the three primary human commodities. It's your responsibility as a parent and spouse and physician to be the best steward of your talents and resources in order to maximize the area under the curve for you and the people you care for. Since time immemorial, people had a relationship with their doctor. Every day, doctors would do house calls and sit by people's beds to treat and heal them. That tradition went back to the genesis of our craft. Sorcerers required you to come to their special temple where they could collect extravagant offerings and fees in exchange for their services in ancient Greece. And this is the man who started it all. Hippocrates prioritized those under his care, and when he said first do no harm, he knew that meant financial harm as well as physical. He became the temple. Wherever Hippocrates went, medicine was with him. He was its essence, just as you will be. He was so passionate about helping people instead of trying to profit off their ailments that he actually burnt down the preeminent temple of sorcerers in Greece. He set a standard that people came to expect. They knew we would spend time with them and earn their trust because we genuinely cared. Our reputation was galvanized by generations of faithful service to those in our care. Physicians became so revered that it was commonplace to name your child after the physician who had delivered them. Now, can you think of any children who have been named after their physician in the past 60 years? I can tell you why you can't. Shortly after World War II, corporations realized there were huge profits to be made by wedging themselves between doctors and their patients. Now, economics are controlled by supply and demand, and a monopoly is achieved whenever you gain control of supply. For doctors, insurance companies had gained control of the supply of patients, and for patients, insurance companies had gained control of the supply of doctors. And they made phenomenal profits from people wanting to see their doctor and doctors wanting to see their patients. But the nature of bureaucracy is to grow, and as overhead for their companies expanded, they had to increase prices to keep up profits for their shareholders. Yellow shows the huge increase in administrators over time, and red shows the abysmal growth in physicians. But black shows the increase in healthcare costs from adding all those administrators. Notice this graph stops right before the Affordable Care Act was signed. And you think to yourself, well, this is why we needed the government to step in and make healthcare affordable. And the ACA probably fixed this, right? But let's get something straight. Lobbyists write bills, not legislators. Insurance company lobbyists wrote the ACA, then lobbied, or what it's called in other countries, bribed, our government with $1.2 billion to pass it. The ACA was written specifically to maximize corporate medical profits and guaranteed health insurance companies 15% profit out of all premiums collected. This health insurance, hospital system, pharmaceutical, government collaboration became the new medical industrial complex, and it grew to astronomical proportions. This is a schematic put out by the Federal Joint Economic Committee to illustrate what a great system was designed with collaboration between legislators and Wall Street executives. Now you're on the bottom left, and to get to your patients on the bottom right, you first have to face that unfathomable tangle of malignant, convoluted bureaucracy. Now, I'm not saying they're bad. I'm saying they're good at what they're supposed to be doing. Our job as physicians is to take care of patients. Health insurance companies have a fiduciary responsibility to maximize profits for their shareholders, and they're great at it. But at what expense? The medical industrial complex dehumanized patients into billing numbers called MRNs. Physicians were no longer dignified as doctors, but instead they became devalued as providers. Now lumped together with the lesser trained NPs and PAs, all of whom were encouraged with financial incentives to attach as many billing codes called ICD-10s to the faceless MRNs as possible so that shareholders could buy yachts with the RVUs that came out of the MRNs when providers buried them with ICD-10s. But let's get something straight. It's well known that America has the world's best doctors. And when being the best meant pumping out ICD-10s to get RVUs out of MRNs, we finally had a scoreboard to behold our greatness. Even during a pandemic, when you would think insurance companies would be going bust because all the people they had insured were now in the hospital, they were making 30% increases in profitability. It's an interesting little detail that health insurance companies have created an incentive for high healthcare costs. They get a set percentage of payouts. It's the classic, if you get a 15% cut of the pie, you want that pie to be as big as possible. Their other little sweet piece of profit magic is called the clawback. Insurance companies use high medical costs as an excuse to charge exorbitant premiums and require outrageous deductibles. At the end of the year, they're allowed to claw back a significant portion of the deductibles paid by their beneficiaries in order to maximize their bottom line. Because of this, from 2019 to 2022, medical profits exploded. But again, at what expense? Those billions have to come from somewhere, and that somewhere is sick people's pockets. Corporations had used government to take total control of the American healthcare system. Insurance companies lobbied the government to mandate that you had to buy their product in order to maximize profits for their shareholders. And if you didn't, then it was the government's responsibility to punish you. The tax penalty for not buying their plans reached over $4,000 by 2017. Now, listen, as a medical student, I couldn't afford health insurance, but my wife had a job, so we had to pay the penalty. It was the ultimate tax on the working poor, and it was so politically harmful that it was rescinded in 2019. But the rest of that massive system survived, and they didn't miss the lost revenue. Doctors and their patients presented them with an enormous opportunity to make colossal profits for the next several years. Now, as doctors, we take the Hippocratic Oath and pledge to first do no harm. But as minions for the medical industrial complex, we helped healthcare become the number one driver of inflation and bankruptcy in America. Why would we do this? Health, wealth, and time are the fundamental human commodities. Was it all worth it in exchange for the great health outcomes we were achieving? I hope not. The quality of our work truly suffered from the focus on Wall Street profits. It actually seems like money may have a tachyphylactic effect on health outcomes. So if we didn't do it for the health benefits we were achieving, then were we on the take? Like, were we doing it for money? I don't think so. This graph beautifully illustrates how terrible our current system is at addressing actual problems. Now, plastics can be ignored because it's highly cash pay and elective procedures. But nobody would suggest that broken bones are the greatest threat to the health of the nation. Yet our insurance system places the highest incentive on being a bone doctor. There is consensus that chronic disease and access to primary care are among the biggest threats to America, period. Yet the lowest incentive is placed on solving those problems in this system. Something I contemplate when I look at this graph is that saying, how does it go? Every system is perfectly designed to produce the outcomes it gets. And that makes me just wonder, like, what incentives were being responded to and who is benefiting from the system being designed this way. But if we're not doing it in exchange for health or wealth, then we must be doing all this in exchange for time, I guess. But apparently not. We got overloaded with patients, then essentially took on a second job creating billing documents. As a primary care physician, you're expected to see 1% of your panel per day. So, like it says here, 25 patients, that's 25 patients or 2,500 patients is the average panel in the United States. So that's 25 patients a day. That's just scheduled though. You still have to see refills through telemed and then any walk-ins. So you get crushed, and then you still have to write these huge billing documents at the end of the day so that you have an invoice to send in for your compensation. Because primary care doctors became so powerless in this system, garbage job offers became the industry standard. Now, every day I receive enticements from moonlighting companies and other hospitals needing doctors. And you will too, once you're out of school and out of residency, you'll be inundated with it. Here's an average offer I received recently. I think it's funny when you look at this, like, did you know that you're actually at 20% higher risk of having a heart attack on Monday mornings than any other time of the week? And if you look at this work schedule, you can see why. So you're going to start me with a 12, then I get to work nines all week. Then on Friday, I get to leave early, but it was still a 9-hour shift. Like, thank you for this wonderful opportunity to torch myself, but I think I'd rather walk into the ocean. Again, seeing patients isn't even the thing you're being paid for. You still have to write the billing documents so you can justify your meager wages. Those documents became so lengthy and cluttered that when you actually need their information, you can't make yourself read them, and you usually can't even find what you're looking for. So maybe we were doing this because it gave our patients more time. Nope. Patients wait an active 26 days, then sit in the waiting room for hours in exchange for a 7-minute visit with their doctor or their mid level, all to receive a referral to a specialist for a problem which could have been handled by their family doctor if there had just been time in the appointment. People that needed to see their doctor literally became so synonymous with being content to wait that the medical industrial complex renamed them from people to patients. So I invite you to contemplate, if our practices harmed the health, wealth, and time of both us and our patients, then why did we do it? I have theories, but I don't have an answer. However, I can show you what happened. Because people couldn't see their doctor, they started getting sicker. Chronic disease went up 700% since the inception of health insurance. But it wasn't just the patients getting sick. Doctors no longer recognized their job and hated the work. A new diagnosis arose: burnout, a label for physicians suffering from the body and mind's natural response to our exploitation. We had been exploited and we were suffering the consequences. Now, there are many different ways to look at burnout, but one thing's absolutely true. Burnout became an urgent dilemma for all physicians. This is what burnout actually means. One doctor kills themselves every day. It's literally more dangerous to be a physician than a soldier, an ice road trucker, or a Bering Strait crab fisherman. And this is all a post ACA phenomenon. It hasn't always been like this. But now, in a time when we're not making enough doctors, we're also losing the equivalent of an entire medical school every year to suicide. Burnout negatively affects the quality of care, including a twofold increase in the odds for unsafe care, unprofessional behaviors, and low patient satisfaction, according to the AAFP. They say burnout is driving physicians to reduce or leave clinical practice, thus contributing to the primary care workforce shortage. The thing is, the primary drivers of burnout are all direct consequences from the dehumanization of working in this medical industrial complex. And here's the worst moral burden that doctors had to shoulder. Patients stopped being the priority. In industry, the customer's whoever's paying the bill. That meant doctors worked for the system, and the patients were just the couriers carrying the money. Everything about this system was unsustainable. But fortunately, some free thinking doctors realized they had never consented to selling their soul to the medical industrial complex. They went searching for our old sacred traditions in medicine, which had become hidden by the fog of bureaucracy. On that journey, they discovered it was their license, not the system, that made them doctors. They had rediscovered the ancestral bridge to freedom that was our medical license. After bringing the first patients across that bridge, they remembered that the joy of being a doctor isn't generating RVUs. It's the friendship, compassion, and trust in the direct relationship between a person and their physician. With that, direct primary care was born, and it did away with the middlemen and bureaucracies fiending to profit off the doctor-patient relationship. Those trailblazers stood up to have their voices heard in Washington and fought to have a direct primary care clause added to the Affordable Care Act. The ACA was adjusted to say that it shall permit a qualified health plan to provide coverage through a direct primary care medical home. Now, I love that phrasing. A home is where you belong. It's your sanctuary. It's the place where you can recover and build strength to take on the outside world. The ACA was further amended to clearly state what it meant by DPC medical home. And with that, DPC was baptized into legitimacy. Now people and doctors are living the happy, healthy lives of times gone by. But at first, people were hesitant to take us back, and rightfully so. We had to convince them that we had seen the errors in our ways and we had changed. But they did take us back, and with open arms, and the DPC revolution took off. There's a saying that I really love. It goes, traditions are solutions to problems that time has forgotten. And I really think we had rediscovered that old problem that Hippocrates did away with. And now that we've returned to our traditions, we're rediscovering the quality of the relationship and the quality of care that he had outlined for us. So what's DPC done for our people? We give our members same day or next day access, prolonged appointments. They can call, FaceTime. I do house calls. Whatever's needed, we can do because we don't have a huge patient load. Remember, I said 1% per day is what a primary care physician is expected to see. And our model, we can only carry about 600. Some people only carry 175 up to maybe 800 is the right panel size in direct primary care. So you're saying you might need to see 2 to 8 patients in a day. That means you can really give them your dedication as their doctor. We can foster relationships and essentially become their doctor friend who cares and can help. They also get their labs, imaging, and prescriptions at outrageous discounts. For example, a CMP in the system costs an average of about $240 to $260. Now, in my clinic, we charge $4.95. An MRI costs over $5,000 in the hospital near me to get an MRI of your knee. We get them at a local imaging center for $475. Lisinopril, the most common antihypertensive medication, it costs $7 per pill if you use your insurance. We give it out for 2 cents a pill. A month of medication is less than $1. Now, we're not pulling any crazy tricks or like pulling a rabbit out of our hat here. Your insurance company isn't paying these outrageous prices either. We're just paying essentially what they're paying, but we do it through a system called client billing, where the DPC doctor is who goes out, negotiates these prices, and acquires all of the services for their patient. We really are a steward. We usher our patient through the healthcare system so that they don't go into the office, get told that they have all these orders and referrals, and then just walk out into the ether wondering what happens next. We really take them by the hand and walk them through the system and make sure that we're looking out for what's best for them both physically and financially. Because there's such a thing as financial well-being. And as their physician, it's part of your responsibility to protect that. Because we don't bill insurance, our members are able to decrease or eliminate their insurance burden because they don't need it for primary care. Insurance is for large, unforeseen expenses, and primary care doesn't meet that description unless you never thought you'd need to take care of yourself. You wouldn't use your car insurance to pay for your annual vehicle inspection or oil change. And if you did, it would be so expensive that nobody would be able to afford it. For the same reason, you shouldn't use your health insurance to pay for your annual wellness appointment or preventative medications. So what we do is we recommend that most of our patients, because they have such great access to care, they decrease their burden so that they have either a high deductible plan or what's called a medical cost sharing plan. And those cost like a monthly premium, what your standard healthcare.gov insurance plan costs. but they still give you that backstop in case you need to go to the ER or get a surgery or something like that. Now, healthcare is the most expensive benefit an employer can offer, but it's critical. Employees say it's the most valuable thing they can offer. But think about this. In 1963, General Motors was the most profitable company in the world. But when they went bankrupt in 2009, it was because out of every car sold, $2,000 went straight to employee health care. According to the Texas government, employers offering direct primary care to their employees save an average of $4,000 per year per employee. That doesn't even account for the increased productivity from fewer sick days and better overall health. But members and businesses aren't the only ones benefiting. There's no more putting the highest value on being a bone doctor. Now we've got primary care being compensated according to its real value. You can significantly increase your income by choosing DPC. And because we're not pinched for time, our members benefit from the full expanse of our knowledge and skills. We have time to work up a complex diagnosis, then read about the correct treatment options. We have time to do procedures we never would have done in a clinic with 24 other patients to see that day. Joint injections, vasectomies, medical ear piercing, hormone replacement, whatever you want, the medical world is now your oyster. And that's great for the people under your care. These statistics are from the Olson Group. They're an employee benefits consulting firm with an emphasis on retirement planning and group insurance plans. And they did their own research. And this is why they say every plan should be built on a foundation of direct primary care. I mean, these statistics, these results that we're getting are really crazy. 30% fewer days admitted to the hospital, 59% fewer ER visits, 62% fewer specialist referrals, 80% fewer surgeries. And that's really because of the access and just the decreased bureaucracy that we're working with. For example, recently, I had a mother call me and say, hey, I just got a call from school. My son cut his head open on something on the playground. What should I do? Do I go to the ER? And I said, no, send me a picture of it when you get to him. Hold pressure. If it's still bleeding, bring him home. And if it looks like something we can manage, then I'll take care of it as a house call. I went over to the house, ruled out concussion, couple sutures, 30-minute visit, no extra bill, nothing extra, no extra fee or anything like that. I'm not a predator. I'm not trying to capitalize off their moment in need. They paid for their month, just like you don't get billed to watch more Netflix series or something. You don't get paid to use me more. Just you pay to have a doctor. You now can rest assured there's always a doctor in the house. And as a physician, we benefit because DPC will always give you the best day with the best pay. Doctors in DPC are able to live the life they earned through all that hard work and sacrifice through their med school and residency years. We're able to do this because we don't have to pay for that yellow mountain of administrators we were talking about a while back. It's just us working directly for our patient. And here's why that really matters. There's also no more convoluted charting. The most used DPC EMR requires 2 clicks to open and close a note, and then you just dictate everything inside of it. I mean, how much easier could it get? And because we're not billing insurance or the government, there's no one to read into our records and audit us. So my notes can literally look like this: Jeffrey, bacterial sinusitis, augmentin, follow-up PRN. No more like 12-point review of systems that people claim they did for somebody who came in for a UTI or something. Like, did you really ask somebody about their sinuses when they're here because it burns when they pee? Your medical documentation is just returned to its actual purpose, and that's recording assessments and plans so that you can remember and exhibit your thought process, period. Now we started from the bottom, now we're here. DPC can work anywhere. This is a map of all the clinics that we have registered right now in America. There's over 2,300 practices in the United States, and we're rapidly growing. I've got a bunch of FAQs here just from previous talks that I've done. One of the things that comes up is, what about people with low incomes? Well, Medicaid and Medicare patients actually really struggle to find primary care because a lot of practices won't accept their insurance. And then they still have a copay and deductibles when they do get that care. So using DPC can actually be less expensive and definitely more cost effective than using their Medicaid or Medicare. So some of our highest utilizers are those patients on Medicaid and Medicare. And because DPC has been shown to be so effective to keeping costs down for benefits advisors and benefits providers like employers, there are currently bills in CMS, that's the Center for Medicare and Medicaid Services, to create an HSA, like health savings account, that can be used to purchase DPC by Medicare and Medicaid recipients. So it would work a lot like food stamps. We're like, hey, here's this card that you can go swipe to pay for your DPC, but the direct primary care practice doesn't ever have to interact with the insurance companies or the government. And that's what's being trialed right now. And probably going to be Texas will be the first state to be doing that. We were talking a little bit about the differences between DPC and concierge and like, is there a difference? What's different? And I'll just say everything. Concierge still is entirely inside the system. It requires people to pay those high annual membership fees, and the patients still have to carry a high level of insurance. Each visit still has a copay, and their insurance gets billed to the max. And concierge is very different also for the physicians, because they have to create those large billing documents and everything that we were talking about, and do all the prior authorizations and all the stuff that comes with being inside the system. They also don't have the autonomy to go out and negotiate those discounted prices on labs, imaging, and prescriptions that you do as a DPC physician. And then what about the national shortage of doctors, right? So we have a projected shortage of physicians by about 40% over the coming years. But physicians currently spend 47% of their time on administrative tasks, primarily charting. So there would be no shortage of doctors if you just removed that administrative burden in the first place. And that's what DPC really does for us. Now, establishing boundaries is an important responsibility for all physicians. Yes, our patients have our cell phone number so they can reach out to us in their times of need, but that's because we own their care and we want to look out for them. And we want them to look to us for advice and advocacy. Realistically, though, because they can access us so easily during work hours, they rarely need to contact us after hours. It comes to about 2 to 6 texts per week on average for DPC docs. And you can set your own boundaries. My clinic's contract states that patients are only to contact us outside of business hours for issues that must be addressed within the next 12 hours. If that request is broken twice, then they're invited to resign their membership. Now, this is relevant to medical students because whether you realize it or not, other people are really looking up to you. Undergraduates, high schoolers that want to be doctors, and they're not quite at the point to have a physician as their mentor, but a medical student is the perfect mentor for them. And it's important for you to get the word to them that we're bringing back real primary care, and make sure they don't get on the wrong boat when they're making their decisions through their medical training journey. If there's someone who's passionate about what being a family physician or a pediatrician or an internist has to offer, then they should stick with it, because we're solving a lot of the problems that have mired those specialties. The DPCA has resources and mentors ready to help you. if you want any more information about that stuff, particularly if you want to start a business or employment or looking for employment, there are many employment opportunities in direct primary care. Members of the Direct Primary Care Alliance, which like I said, you guys have access to that for free. You can review those employment opportunities on our website. I can send this flyer out later if anybody would like to see what a direct primary care offer looks like compared to one of those offers from the system, like I showed you before. Now, there are many benefits to being a resident and medical student in the Direct Primary Care Alliance. We've negotiated great prices for all of the resources that you could possibly need, be it question banks or other resources to look up clinical information so that you're not paying full price. And then we also can give you the opportunity to do clinical rotations in a direct primary care clinic. And then you get discounted tickets to the annual Direct Primary Care Summit. And then, of course, you have access to all the mentors, and then you can get volunteer hours, and there are leadership opportunities as well. But here's why it's really important. Joining the Direct Primary Care Alliance enables the DPCA to represent you and show your belief that medicine should focus on the health of people.
Is the video supposed to have sound? Just double checking.
Oh, yeah. Are you not able to hear it?
No, 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 not right now.
Okay. We can just skip it then. Hey, so here's the link that anybody can use if you'd like to learn more or join the Direct Primary Care Alliance as a doctor in training, or a RAMS as we call it. All of those resources would be available to you after you go through that sign up sheet, which, like I said, is free. And with that, happy to take any questions that we might have. Let me see if I can pull up the chat.
Yeah, so thank you so much, Dr. Moore. It was absolutely phenomenal presentation. I was writing down questions as we were going along, and then you answered a lot of them with your FAQs. But before we start with questions, for the sake of time, I'd kind of like to ask the audience if they have a question, you just type it into the chat. And I'll ask a few questions, and then we'll open it up to the floor. So again, I'd like to say it's absolutely phenomenal presentation, one of the best I've heard on the topic. And I just had a couple comments before I got to some of the questions. So I think a lot of your charts and graphs speak a lot to the nature of the problem that currently exists within the medical industrial complex, particularly the growth of physicians and administrators graph, where it shows, physicians are only going up. Yeah, it's absolutely wild. And I think I've seen that in a lot of other places too. And then your concept of health, wealth, and time, and how that needs to factor into physicians' well-being. But one of my questions was, the data is just overwhelmingly obvious that this is better for patients. It's better for physician well-being. It's decreasing chronic illness. But one of the questions I run into a lot amongst my peers is, it works so well, but I think people struggle with understanding what the barrier to entry looks like. I know you spoke a little bit about how do I get started? But question one was there a critical moment or breaking point where you decided that this is what I need to do? You said you learned about it in your second year of residency. And then that's question one. And then question two would be, what was it like getting started?
Yeah. To answer your first question, I had my second year of residency. I was at the point where I was seeing 20 patients a day in clinic, and just reaching that point and seeing how dangerous that is, really. It can be pretty unnerving, just like running from room to room, and like your nurse is in the room a long time. So we say 20 minute appointment, but like the statistics show it's more of like 7 minutes. and that person's there for like two medication refills, which you might not want to refill those medications. You might think that, hey, they actually need a med rec and those need changed. And they also have like a question about some chronic pain thing. Oh, but then they have like a red flag symptom that you really need to dive into. And you just feel like you're constantly neglecting your patients and you're not giving them your full capability. And so I was really struggling with that. And actually, my wife and I was so focused on getting out of medicine as a second year resident, and I was pretty unconvinced that I'd made a huge error in judgment. And so my wife and I actually started a real estate investment company, and we were like going all in with that stuff. And then I had some positive action and was able to go to flight surgeon school in residency. And when I was at flight surgeon school, I met these doctors. It was all pretty much all family doctors in there, and everybody was like dragging because we just get run into the ground constantly. But there were like three guys who were super happy, and they were National Guardsmen. And I asked them what their secret was. What are they doing? And they said, "Oh, we have a direct primary care clinic." This was like back in 2018, so I had never heard of it, and it wasn't really a thing that many people had heard of. And they explained it to about six of us. I'd say I just had an absolute like light bulb moment, like complete my life redirected. I'm never looking at anything else. And like one of the other guys was like, that seems intriguing. And the other four were just like, I don't get it at all. I don't see why this doesn't even make sense to me, which is funny. Like some people get it and some people just don't. And I don't know exactly what the difference is. But then for getting started, it's such a well trodden path now. The first people who did it, they really were jumping out into the unknown. But now there's so much literature about how to start your direct primary care practice. There's like literally four books that are essentially have that exact title. So if you just read all of those books and pretty much exactly what's in them, the line for primary care goes out the door and stretches over the horizon. So once people start finding out that you're going to have availability, then you're you're getting patients coming in anyway. Now, you do have to explain to them that it's a new model and it's not what they are used to, but it's what their grandparents were used to, kind of thing. And it works the same way as everything else. And our generation, like the millennials and Gen Z, they're very familiar with subscription type models anyway. So it kind of makes sense that like I would just have a doctor on retainer that I would use when I need, but not just be like trying to avoid going to the doctor because I have no idea what it's going to cost. So honestly, uh, I got out there and I talked with benefits advisors, and it's like you'll find as a physician, there's two people that you have to like hold back. You're actually at risk of too much opportunity. Number one, that's bankers. The banks will find out you're a physician and they're like, how much money can I give you? So be careful with that. It can seem tempting. The second is benefits advisors. They're going to be like, how many patients can I throw on you right now when they find out your direct primary care? Because you save, they're in the business of going out and trying to save employers money with setting up their benefits plan. Direct primary care, especially when paid with a health share, saves those employers 50%. Every year for the past 2 decades, those benefits advisors have walked into the boardroom and said, hey, I'm sorry, your healthcare spend is going up 10%, 15% this year. And when you bring a DPC online and they're able to come in and be like, hey, I'm going to decrease your spending by 50%, there's more business than you really know what to do with at first. Now, that's if you have yourself set up well and listen to the My DPC Story podcast and go to the DPC masterminds and join the Direct Primary Care Alliance, and you'll be well prepared. But it is possible to just dive into this and get hurt. I'm sure. I don't know of anybody that's done that, but I'm sure it is with anything else. Like Warren Buffett says, investing isn't risky. Being naive is risky. So going in and just trying to do something with Navite, yeah, it's probably risky, but there's so much information available. Like we have DPC University on the Direct Primary Care Alliance website, and just reading those articles alone will prepare you to have a successful practice.
Yeah, thank you so much for that. Another comment I had too is I really like the way you phrase things, and very eloquent too. One of the things you had commented on was the physician burnouts from exploitation. I had never kind of heard it phrased that way, but I thought that was very eloquent. And there was one thing I also kind of, not as much of a question, but a comment that I found particularly relevant. So right now I'm a third year medical student, actually rotating at a direct primary care clinic for my family
Hey,
med
right on.
rotation. Yeah. And
That's great.
the provider I'm with, the physician I'm with, she runs into the issue of patients kind of maybe reaching out more than they should. So for our listeners who are
Absolutely.
interested in getting started, I really wanted to emphasize the point that you made where you said, if you're going to text after hours, it has to be something handled in the next 12 hours. And if you violate that 2 times, you're, invited to revisit your contract. I think that was something that a lot of people don't think about, and then they run into this issue that where
100%.
people are
Training your
taking advantage
patients
of
is
you.
very important. Yeah, part of our welcome package is actually a little magnet that you put on your refrigerator and says, like, I need to see my doctor. Do I need to see him within 12 hours? If it's yes, then is it an emergency? Go to the ER and text your doctor. If it's yes, but it's not an emergency, meaning doesn't threaten life, limb, or eyesight, then text your doctor. And more than anything, somebody texts you and it's not something you need to see him in 12 hours, but it is something urgent that you can tell him, like, hey, for this like horrendous migraine or this chest pain that doesn't sound cardiac or whatever, do this thing and I'll see you in the morning. Come in at 8 a.m. I don't mind to do that. That saves me so much work on the back end when I'm not doing an ER follow up. Instead, I'm just being like, hey, I'm your shepherd. I want to take care of you. And really, what I have to offer is just like gently directing people in the appropriate things. Then that makes it a lot easier. And if you have patients that are struggling to understand that, then you just need to you put it in writing and they sign it right up front that like they understand that, hey, if the physician determines that these were inappropriate, then we're giving them a lot of access, and if they disrespect that, then they might not merit it. So they're invited to leave the practice, and we set them up with another physician within 30 days, like we need to.
And then we have a question in the chat here as well. It was actually going to be one of my next questions as well. So Dr. Morton had said, from the perspective of a DPC physician, are you seeing a similar growth in other types of cash practices, imaging centers, surgery centers, and maybe direct specialty care is the word for it?
It seems like the private pay of medicine has just gotten so much traction now that we're approaching the critical mass where everything's wanting to go that way, because it's just so much easier to run a business when you don't have all that administrative burden. And it's just like I always thought it was funny when I came into medicine, and like just doing the most basic thing in clinic was this huge administrative rigmarole. And then as a DBC doc, I can be like, oh, you're a sick person and I'm a doctor with medicines. You have money and I'm doing this for business. Like, let's make a deal, right? It's like literally that simple. So other places are catching on to that, and they jump at the opportunity to use cash pay patients because you cut down on their overhead and they get paid immediately. They don't have to fight the insurance companies for 2 months. Insurance doesn't reimburse you for a couple months. You have like a 2 to 3 months lag from when you bill for a visit and when they pay. But usually it's like 6 to 8 because you have to fight the insurance for so many things on the way, especially for these specialists. So yes, cash pay imaging centers, cash pay surgery centers, all types of specialists are open to be cash pay. A lot of times they have a smaller office too, and you can just literally you can have a friend that's an endocrinologist or something like, hey, what would you charge for a cash pay visit? And they'll be like, yeah, $150. But also there's a lot of tech that's come in. So like I use this piece of tech in my EMR where I have all these specialists who are nationally licensed access to me like a text. So just as easy as reaching over to the group chat here, I can reach over to my text in my EMR and say, hey, I'm taking care of Jeffrey. He's had this type of chest pain. Here's his heart score, or here's his inner chest score, and here's his EKG. Here's what I think it looks like. What's your recommendations? And they can say, agreed or disagreed, do this next. And if it's this thing, send them my way. And if it's not, give them aspirin or whatever. And it's that easy. And they get paid through that service that they don't bill me or anything like that. So there's people are brainstorming, really smart people are coming up with great ideas and trying them to see what works and what doesn't. And so a lot of ancillary services and specialists are getting involved.
Thank you. And kind of piggybacking off that too, one of the questions that comes up to me when I try to explain this model to friends and family, when you come over into this specialty care, side of things, one of the things that comes up is, if you're not insured, what do you do when something comes up? So my question is, I always tell people you can get catastrophic insurance coverage, and you had mentioned that, I believe, in your presentation. But I don't totally understand what that looks like. So you've got all of your basic needs covered from the primary care side of things. What does a catastrophic insurance cover? I understand, trauma. You said surgeries, but like, what about more insidious things like cancers or neoplasms or things like that?
Yeah, and I'm like uniquely well versed on this recently because I've been in these deep talks with a insurance and health share company this during this week. And I can attest that what it looks like now, unless somebody had a pre-existing condition, I would never recommend that they use insurance. And most of the leading benefits advisors that I talk with they don't have health insurance. Um, Health insurance is great if you have a pre-existing condition. If you already had that neoplasm discovered and you're starting chemo, health insurance, they can't deny you coverage. And at that point, you're kind of in a different position where you don't want a high deductible emergency plan, right? Like you want something that's going to really be covering a lot because you might actually get more money out of the insurance than you contribute. Now, employers will never be that way. If an employer pays, uh, if they have their insurance pay out $1 million one year and they pay $1 million in premiums, the next year their premiums are going to be raised to $1.3 million to make up for the 15% the insurance lost last year and give them the 15% they need this year. So, steering people away from a high deductible plan, which usually is like it's a PPO, which means you can only see certain providers. It's a preferred provider network is what that means. And then you have to pay less if you see the providers that they want. And it's usually a high deductible, like we said, $5,000 is about the highest. Your For my healthy family of four, my premium every month for that would be about $1,100. All right, that's before I add in direct primary care. That's through the healthcare marketplace. Now, if they use, on the other hand, a health share, what a health share works like a shared HSA, right? An HSA is a savings account, a tax preferred savings account that you contribute to. And if you have any health expenses, it comes out of that. All right. Now imagine like you, me, and Sonny all shared in this one pot where we each contributed $200 a month. And if you got sick, then Sonny and I's money went to help you. And if I got sick, then you and Sonny's money came to help me. But there's no big corporate organization on top of it trying to make a profit for their shareholders. It works a lot more like an index fund versus a mutual fund, right? So there's a small management fee as that money goes by. Now, you can set your deductible to be high too. So you can make your deductible, which are called your non-shareable amount, like $5,000, like it would be with that high deductible plan. But now you've got that same backstop and it's unlimited. So it's not like, if you get cancer and then you need chemo and you also need radiation, then it's going to cut off. It's unlimited once you meet that unshareable amount. And for my family, that came to $373 for a family of four. So 373 versus 1,100 without even having direct primary care. So if you throw on direct primary care, which is, for four people, that's going to be like $350 on top of that. So now we're under $700 for having all of DPC, but then also a backstop on there for your family monthly, as opposed to like the $1,100 plan where it's like, I was talking with a man this morning, his brother tried to get into with a primary care provider. It was 90 days before he could see his primary care provider. The guy was having chest pain and just like chronic low grade chest pain when he would walk. 53 years old, died. He was supposed to see his doctor 2 days later. He had waited 88 days to see his doctor. And it's just like, that's why we have such better outcomes. In direct primary care, if somebody starts having, like if you have a CHF patient and they say, hey, I'm feeling heavy, my feet are swelling, you can say, all right, swing by the clinic. I'm going to put an IV in your arm, give you 80 of Lasix in a bottle to pee in. I want you to come in tomorrow morning with your bottle. We're going to look at the bottle and we're going to put you on the scale and weigh and see how you're feeling. And by doing that, you can avoid the ER visit and the likely subsequent admission. That's how we decrease those admissions, like was shown on those Olson group statistics. And that's just care that like nobody has access to.
All right. Well, I think we're about at the hour, so we'll probably start wrapping up here. And again, thank you so much for your time. And also, again, want to emphasize that appreciate your service for the country, and it's not
Thank
an
you.
easy
It's been an
sacrifice to
honor.
make. So, once again, absolutely phenomenal presentation, and I'll make some closing remarks, and we'll wrap up. So, this video will be available for our listeners on YouTube no later than Tuesday this coming week. And we encourage you to visit the YouTube channel to watch other videos like this one, covering multiple topics of interest to all of us in the medical community. And I want to thank Dr. Moore again for his time, and the participants for their time in this video as well. And don't forget to bookmark the Benjamin Rush Institute's website, Facebook, and Twitter pages for other upcoming events. And we encourage you to offer up topics that you would like us to cover in the upcoming months ahead. And we'll be happy to address those with the team. And the virtual event series is produced by the Benjamin Rush Institute, which is a nonpartisan, nonprofit institute dedicated to promoting patient-centered, doctor-focused solutions for the practice of medicine. And this series is funded by BRI supporters like you. And like all BRI productions, it is hosted by medical students, for medical students, and healthcare professionals. And I am Jeffrey Bettag, a third-year medical student at St. Louis University School of Medicine. And on behalf of Benjamin Rush Institute and all our students, we wish you a happy holiday season and a happy and healthy new year. Thank you.
Thank you very much.